Hi, my name is Dr. Rachel Potter, and I'm a consultant clinical psychologist working at Aneurin Bevan University Health Board in the Learning Disabilities Directorate. And I'm going to be talking to you today about dementia and individuals with learning disabilities. I only have a short time for this presentation, so unfortunately, I won't be able to cover everything. But instead, I'm going to cover some key points around dementia assessment, diagnosis, and interventions for individuals with learning disabilities and their carers. So a good place to start is to think about what is a learning disability. A learning disability is a significantly reduced intellectual ability and significant difficulty with everyday activities. For example, things like household tasks, socializing, managing money, and it affects someone for their whole life. So individuals with a learning disability tend to take longer to learn, and they may need support to develop new skills, to understand complicated information, and to interact with other people. You may also hear the term intellectual disability, and that's often used interchangeably with learning disability. Each person with a learning disability is unique, and they're going to have their own set of skills and their own set of needs. For some people with learning disabilities, they will live independently and need very little support from other people. For other individuals, they will need support throughout their life and with all aspects of daily living. And most people will fall somewhere between those two. So why are we thinking about dementia in people with learning disabilities? I hope this graph explains why this is an important topic. You can see from this graph there are three lines. The solid line is showing people in the general population. The dashed line is people with an intellectual disability, and the dotted line is showing people with Down syndrome. You can see from this graph that individuals with a learning disability are more likely to develop dementia, especially those with Down syndrome, and at a much younger age. This second graph shows similar information, but it breaks down the data into males and females. And again, from this graph, you can see that the bluey purple bars are showing people with Down syndrome. The pink bar is people with a learning disability without Down syndrome, and green is the general population. And again, you can see that many more individuals will experience dementia and at a much younger age. So let's break that down a little bit further. For people with a learning disability but without Down syndrome, there are 2.7 times the number of cases of dementia when allowing for age and sex. At present, we don't know why this is the case, and much more research is needed, but genetic factors or neuropsychological factors that are associated with the individual's learning disability may be the cause. And you will have seen from that graph that dementia is even more prevalent for individuals with Down syndrome. In fact, it's 107 times the rate when adjusted for age and sex. So 1 in 50 individuals with Down syndrome will develop dementia in their 30s, and this rises sharply to more than half of those who live to 60 years or older. And studies have shown that by the age of about 40, almost all individuals with Down syndrome develop the changes in the brain associated with Alzheimer's disease. However, not all go on to develop the clinical symptoms of dementia. The reason for the increased risk amongst people with Down syndrome has not been fully identified, but it's thought to be linked to the extra copy of chromosome 21, which most individuals with Down syndrome have. And it's this chromosome that carries the amyloid gene that is thought to play a role in Alzheimer's disease. So we know that dementia is more prevalent amongst people with a learning disability. It's worth saying that the signs and symptoms of dementia in this population are broadly the same as for the general population. However, you may notice that there are changes in behaviour and personality or loss in daily living skills that are seen before memory problems, and that's particularly true of individuals with Down syndrome. And as with the general population, there can be many other reasons why someone is experiencing the changes associated with dementia. And it's helpful for GP to complete some routine tests before referring for further assessment to rule some of these things out. And I'm going to talk a little bit about what some of those other reasons might be a little bit later. If the routine tests do not indicate the reason for changes, then the GP should refer the individual for specialist assessments. So for some people with a learning disability, they can access general services such as the memory assessment services, with reasonable adjustments being made. But for most people with learning disabilities, they should be referred to their local community learning disability team, or CLDT. And this is because CLDT professionals have expertise in working with individuals with a learning disability, and it can be difficult to diagnose dementia in an individual with a learning disability using standard assessments. It's also recommended as best practice in the Royal College of Psychiatry and the British Psychological Society guidance issued in 2015. And I'm going to talk a little bit more about some of these difficulties with diagnosis a little later on. Community learning disabilities should link in with generic services where needed to make sure that the individual and their carers are receiving the best care. Some of you may know about learning disability services, and for other people this might be something new, so I thought it would be useful to just explain a little bit about our secondary services. So individuals with learning disabilities may at some point need additional support to that offered by generic services, and this is provided by secondary learning disability services. So each area or locality will have a community learning disabilities team, or CLDT, and these are broadly similar to a community mental health team, or CMHT. Typically, a community learning disability team will include a range of professionals, for example, community nurses, clinical psychologists, psychiatrists, occupational therapists, speech and language therapists, physiotherapists, and so on. Community learning disability teams are often linked with the local authority learning disability services, so social workers and healthcare professionals will often sit together, but this is not always the case. And community learning disability teams tend to support individuals from the age of 18 through to end of life. Some services may also support children, but on the whole, they're usually two separate services. So coming back to assessments for people thought to possibly have dementia, when the individual is referred to the community learning disability team, they will be placed on a memory care pathway or a dementia pathway or something similar. This is a multi-professional approach to ensure that a holistic assessment is completed. The aim is to rule out the other causes that can have similar presentation to dementia. And there's a list of things that you will probably be familiar with, things such as depression, sensory impairments, life changes, physical health conditions, medication side effects, and so on. Just thinking about a couple of those in more detail, let's start with life changes. So people with learning disabilities in their middle age can face a number of life events, such as the loss of a parent or a long-term carer, moving away from home, or the loss of day activities. In some individuals, the impact of life events may lead to a regressive state with apparent loss of skills. And changes in routine, such as new structure to day opportunities or changes in support staff, can cause profound reactions in an individual with learning disabilities, leading to functional decline and a dementia-like presentation. Similarly, if we think about sensory impairments, people with a learning disability in general, and those with Down syndrome in their middle old age specifically, are likely to develop hearing and visual impairments. And thinking about physical problems, we may need to think about conditions such as hypothyroidism, uncontrolled epilepsy, and chronic infections. All of these things need to be considered because they have a similar presentation to dementia, and we need to rule them out. I mentioned earlier about some of the difficulties with completing assessments of dementia in people with learning disabilities, and we cannot complete a one-off assessment, as is sometimes the case in generic services, nor can we use standardised assessments. So the Community Learning Disability team will complete longitudinal assessments. So that means assessments over time, where we look for a decline in functioning that is indicative of dementia. The assessments focus on cognitive skills, communication, and skills of daily living, and we assess for changes for that individual and compare to their own baseline level of functioning. So just to go into that in a bit more detail, there is a great variability of functioning within the population of people with learning disabilities, and comparison with peer-related norms is not possible as it is with mainstream dementia assessments. Assessment of decline needs to be personalised to each individual with their own unique baseline of functioning, being the comparison when concerns arise. The assessment will include informant and carer interview, direct observation, as well as gathering knowledge from members of the multidisciplinary team. It can be quite a complex and sometimes quite a time-consuming process, but we try to make this as easy for the individual and their carers and to complete the assessments as quickly as we possibly can. So following this period of assessment, the multi-professional team will consider all the information gathered and will decide whether the individual has dementia or whether there is another reason for the change in presentation. And often this formulation is completed within the Community Learning Disability Memory Clinic. If they are given a diagnosis of dementia, then this is shared with the individual and their carers by the most appropriate person from the Community Learning Disability team, and in a way that is helpful and maximises their opportunity for understanding. The diagnosis and what it means may be shared in small chunks of information over time. The Community Learning Disability team will also inform the individual's GP and provide the read code for the specific dementia that they have been diagnosed with. Following diagnosis, then, the individual and their carers will receive support from the Community Learning Disability team, depending on their needs, and the support and intervention that they receive will change over time. Many of the interventions that we provide would be similar to those provided to people in the general population, but with some adaptations and adjustments to make sure that they're meeting the needs of the person with a learning disability and their carers. Here are some of the interventions that they may be offered. So we might provide training and support for carers. We might provide ongoing support for the individual and their carers to help them understand the diagnosis and what it means for them. We may provide support to help the individual maintain their skills over time. We may think about making environmental adaptations, make suggestions around memory aids or assisted technology, or communication aids. We may provide support with their emotional and psychological well-being, and that might be for the individual and it might also be for their carers. We might support with behaviours that have been described as challenging. We may complete life story work, cognitive simulation therapy, intensive interaction. We may support with medication or concentrate on physical health interventions. We make referrals to third sector organisations such as the Alzheimer's Society for their support for both the individual and the carers. And we will be supporting them around end-of-life planning and care. Learning disability services are increasingly offering individuals with Down syndrome a baseline assessment around the age of 30 to support assessment and diagnosis in the future. This is because we know that there is that 107 increased risk of developing dementia that we talked about earlier when we were looking at those graphs. So people with Down syndrome are at particular risk, and therefore we offer a baseline assessment around the age of 30 when their functioning is at its best, so that in the future, should there be any concerns around dementia, we know how they were functioning at around the age of 30, so we can make a comparison with their own baseline. And this speeds up the assessment and diagnosis process. More work is needed to ensure this is happening routinely across Wales, and it may be possible to offer this through primary care services in the future. There is also work underway to explore whether annual health checks completed by GPs for individuals with a learning disability could include a brief cognitive screening assessment. So to summarise, individuals with a learning disability are more likely to develop dementia, especially those with Down syndrome and at a younger age. The signs and symptoms of dementia in individuals with a learning disability are broadly the same as for the general population. However, changes in behaviour and personality or loss in daily living skills are often seen before memory problems, and this is particularly amongst individuals with Down syndrome. Community learning disability teams undertake holistic, multi-professional assessments in order to diagnose dementia. And following diagnosis, professionals from the community learning disability team will provide interventions depending on individual need, and this will change over time as the dementia progresses. We also link in with general services and the third sector to ensure that the individual and their carers receive the best care. And services are exploring ways to improve baseline assessments and cognitive screening, particularly for those with Down syndrome. There are a few references and resources here that you might want to look at to get more information. The Dementia and People with Intellectual Disabilities guidance document mentioned there first is really helpful and provides lots of information. And the Alzheimer's Society and mencap.org.uk also have really useful information on their websites. I hope this presentation has been useful. It's a short presentation, so I haven't been able to go into lots of detail, but I hope that it gives you an introduction to dementia and people with learning disabilities. Thank you very much for listening.